Just let me know when it gets started. Okay, so good evening everybody, good afternoon everybody. I hope you can all hear me. Am I audible, guys? Just let me know a quick thumbs up if you can let me hear me clearly and hear me clearly on this. We'll get started. Yeah, so just waiting for you guys confirmation and we'll get started, guys. We'll discuss all the important questions that came. This time the FMGE exam was pretty much doable. I would feel, they have tested you on the very standard concepts only, and I hope most of you have done a good exam. And let us discuss some important questions that came, all the relevant radiology questions. There are about 15 to 16 questions I have collected out, and I hope you have answered most of them correctly. So let's look at the first question here. What is this one, guys? Identify the given modality and diagnosis. What was your answer for this? Interact karte rehna, keep talking so that it is more engaging and I can understand what you have done. Now, what is this question? So first of all, look at the image here. In this image, I hope you can see that the cortex of the bone or the bone is appearing black. So when the bone is black, it is MRI. So so this image is a MRI image. And what do you see here? In both the kidneys, bilaterally, you see multiple cysts. So you can know this is MRI of a polycystic kidney disease. MRI of polycystic kidney disease. Bilaterally enlarged kidneys with multiple cysts diffusely in the parenchyma, right? So this is different from a childhood polycystic kidney disease. This is an autosomal dominant polycystic kidney disease. How can we say that? Remember, in autosomal recessive polycystic kidney disease or a childhood polycystic kidney disease, you would have cysts which are more perpendicular to the renal cortex or the renal capsule. Whereas in adult, you have this irregular cyst which give that Swiss cheese pattern and all, right, on the IBP images. So such irregular cysts. So this mostly is a MRI of a polycystic kidney disease. I hope you got this right. MRI, multiple cysts. Okay. Yeah. So you can see here, either you may be given coronal sections like this, or you may be given an axial section. Look at the bone, right? If the bone is black, that is MRI, and you see multiple cysts in both the kidneys. This is again your polycystic kidney disease, okay, the adult polycystic kidney disease. And look at this image. How do you see the bone here? Way to see for the bone here on this image. In this image, can you see the ribs? How is the bone? Can you see the pelvic bones? How are they? They are appearing white. The cortex of the bone is appearing white. So if the bones are white, the ribs, the pelvic bones, they are white, and you are shown the kidneys like this. So this is your CT scan image showing the polycystic kidney disease. And you can also see some hepatic cysts, hypodense areas in the liver also, right? Many of the times, these polycystic kidney disease also have associated hepatic cysts. So when you see the bone, cortex of the bone, you decide that. And what were the other options? One was, I think, IVP image given. And how would an IVP would be? IVP, nowadays we are not doing it, but if at all there is an IVP image, it is a radiograph basically, right? A contrast study. So where you can see this calyceal system completely splayed and irregular, right? You have irregular and splayed calyceal system because of the irregular cysts, right, in polycystic kidney disease. So this is how you have your polycystic kidney disease. So let's move to the next one. This is very standard question. Identify the pathology on the given barium study. I hope all of you have got it correct. So this was a diffuse esophageal spasm. What is this? This is classic corkscrew appearance. Okay, we all know this thing. We have a bird beak on achalasia cardia, right? And if it was nutcracker, the barium studies generally appear normal on a nutcracker esophagus. Whereas diffuse esophageal spasm, you have this corkscrew appearance of the esophagus. Yeah, this question. This has been a repeat from NEET-PG exam. Okay, so it's always important when you're preparing for your FMGE exams, all the future aspirants, it is important that you do your last year's questions of not just your FMGE, but also try to touch upon at least couple of NEET-PG papers, the recent NEET-PG papers. And this was asked in the exam, in the NEET-PG also, and in your FMGE exam also. So look at the site of the foreign body on this image. What do you think? Where is it located? I keep telling this question again and again. this is a coin that is located posterior to the tracheal stripe. So if you can see anteriorly, this is the tracheal stripe we have. This is the tracheal stripe, a black lucency that is present. And you are seeing this is posterior to the tracheal stripe. So this is the coin in the esophagus, So if you are having a coin in the esophagus, on a frontal radiograph, it appears like this. And on a lateral radiograph, it appears posterior to the tracheal stripe. Now, the way to understand whether it is a coin in the esophagus or coin in the larynx, okay, the coin in the trachea or the larynx, is to understand that in the larynx, we have vocal cords, right? So, we have vocal cords. So, if the coin has to enter the trachea in the frontal plane, it will enter in a sagittal view like this. So, this is coin in the larynx. And when you see it in a lateral radiograph was given in the exam, and if you see in the lateral radiograph, you see the coin in the tracheal lucency. You will see it in the tracheal lucency. So, hamesha try to remember this thing. So, when you are given a question of the coin, first understand how it would enter the trachea, right? When you have vocal cords, it would enter the trachea in a frontal radiograph in a sagittal plane. And when you see on a lateral view, obviously you will see the coin completely in the tracheal lucency. Whereas if you see like this, that in the frontal plane it is in a completely, you are seeing it completely like this. So coin can never enter into the trachea like this, right? So it can enter in the esophagus, but not in the trachea, because trachea has vocal cords. In the larynx, we have the vocal cords, so it cannot enter into that in that fashion. So here, this is a coin in the esophagus, coin in esophagus. So either you are given a frontal image or a lateral image, you should be able to pick up where the coin is. I hope you are clear with this. Is this clear, guys? I hope, this is something we teach regularly in our classes and all. I hope most of you have got it right. But you have to be careful. Kahan pe tha? That image, if you have seen it carefully, then you have to decide it. Next thing. Another question. So, Mrs. X, a 35-year-old female, presented to the emergency with upper abdominal pain radiating to back. Abdominal pain radiating to the back was given. An X-ray showed colon cutoff sign. So, very standard X-ray finding of acute pancreatitis. So, colon cutoff sign is feature of what? Acute pancreatitis. Now, what happens is when you have an inflamed pancreas, right? So, the adjacent transverse colon, because of the inflammation, it undergoes spasm. So, no air comes into the descending colon. There is a colon cutoff because of the spasm that occurs, because of the colonic spasm. The colonic spasm that occurs because of the adjacent inflammation in the pancreas, and that is called as a colon cutoff sign. It's a very important radiological sign that you see in acute pancreatitis. So if you see, this is how you see. So you can see this is the transverse colon, and you are seeing this tapering of the lucency of air in the transverse colon here, and you don't see much air coming into the descending colon. So this is your classic colon cutoff sign. Any other signs you remember? Any other signs of acute pancreatitis? On radiographs, on CT scan. What are the findings, radiological findings? On the radiographs, what do you see? On the radiographs, we see a gasless abdomen. Why gasless abdomen, guys? Why do you think we have gasless abdomen in acute pancreatitis? Because of repeated vomitings. The patient has repeated vomiting, so nothing much will be left behind. You have a gasless abdomen because of repeated vomitings that you see in acute pancreatitis. And what is the other thing that you see? You see a sentinel loop sign. It's a non-specific sign where you see small bowel ileus around the inflamed pancreas. You will see a small bowel ileus. And another radiographic finding is this colon cutoff sign that has been asked in your exam. So colon cutoff sign, because of the inflammation, the adjacent transverse colon. The transverse colon undergoes spasm, producing this colon cutoff sign. These are seen on the X-rays. And what is the finding that you see on CT scan? Can you remember any finding on the CT scan? On the CT scan, you see a renal halo sign. So the fluid, because of the inflammation in the pancreas, there is peripancreatic fluid collections, and these fluid collections go bilaterally into the renal fossas, right? And the renal halo will be there because of the perirenal fat also. So you will get that halo because of the fluid collections as well as the fat around the kidneys. Everything, the entire pancreas and the adjacent mesentery will be inflamed, but you will see that the renal halo is maintained. So that is called as renal halo sign, a finding in acute pancreatitis. That is the CT scan finding. Are you clear with this, guys? Are you clear? Right? So let's move forward. I hope you got this right. Correct? Kare nahi kare aap log? Right? Got this right? Gasless abdomen, yes Oma. Sir, try to explain in English mode. Okay, निशान, ठीक है, करते हैं. यहाँ तक तो समझ में आया आपको? तो कोलॉन कट ऑफ साइन इज बिकॉज ऑफ इन्फ्लेमेशन ऑफ द पैंक्रियास. कोलॉन में स्पाज्म होता है, ट्रांसवर्स कोलॉन स्पाज्म होता है, तो यू गेट अ कोलॉन कट ऑफ, राइट. चलो, दिस इज व्हाट आई वाज टेलिंग, अ renal halo sign. तो यहाँ देखिए आप लोग, this is a CT scan, right? This is not an X-ray, this is a CT scan. The bones are white, so this is CT. And this is the right kidney, this is the left kidney, and you can see the pancreas is all inflamed, edematous, swollen pancreas is there. And what do you see adjacent to the pancreas? Adjacent to the kidneys, you are seeing this halo, this black color area around the kidneys. So this is called as renal halo. So everything else is appearing inflamed and hazy and edematous, but the halo around the kidneys is maintained. This is called as renal halo sign, a CT scan finding of acute pancreatitis. So ये दोनों याद रखिए आप, colon cutoff sign on X-rays and the renal halo sign on the CT scans in cases of acute pancreatitis. The other signs I told you, gasless abdomen because of repeated vomiting in the patient, and a sentinel loop sign because of the small bowel ileus. Clear? Chalo. The next one we go to is the next question, and this is very standard question repeatedly. Even in NEET-PG they ask 2 questions on fast, and even in FMGE they test you heavily on the fast, right? Fast examination. So an RTA patient suffered blunt trauma to the abdomen, brought to the emergency room. You are the doctor treating the patient is unstable, blood pressure is less, basic resuscitation was done, fast is performed, he remains unstable despite giving intravenous fluids. What should be the next step in the management? So if you remember the protocol of fast, right? I teach you this in our classes also. Whenever you have a patient with blunt trauma abdomen, what is the first investigation that you like to do? Blunt trauma abdomen patient, he comes to you. What is the first investigation that you do in your emergency room? Not in the radiology department. This is done by the emergency physicians, right? In the emergency room. This has to be an ultrasound, fast or e-fast. Fast or e-fast. This is basically an ultrasound, right? Focused assessment with sonography for trauma. So the first investigation or initial investigation agar pucha gaya, or first investigation agar pucha gaya, you have to answer it as ultrasound, which is nothing but focused assessment with sonography for trauma. And if fast shows hemoperitoneum, if you are seeing fluid, especially in the right upper quadrant, this view is the most sensitive view for looking at hemoperitoneum in the Morrison's pouch, in the right paracolic gutter. So these are the 4 views, the first in the subxiphoid, the second in the right upper quadrant, the third in the left upper quadrant, and the fourth in the pelvic. So especially when you see hemoperitoneum, it is considered to be a fast positive. And if you don't have hemoperitoneum, no hemoperitoneum, right, so you're not able to see the fluid. So this is fast negative. And when you have a fast negative patient, right, what do? You observe and repeat if required. If the blood pressure is falling down, you repeat fast. Otherwise, you keep him under observation, right, if the fast is negative initially. Then what would you do if the fast is positive? So as in our question, they clearly mentioned fast is performed and is positive. They clearly mentioned that fast is positive. So already the fast was performed. So what is the next step? What is the next step, guys? The next step is to look at vitals. If the vitals are stable, then we perform a CECT, contrast enhanced CT scan, to know which organ is bleeding. Is it a liver that is, having the extravasation? Is the spleen is having the contrast extravasation? So you need a contrast study to look for which organ is bleeding. So this is CECT. But if the patient is unstable, you cannot send him to the radiology department and get contrast studies done. Already the blood pressure is falling down, the patient is collapsing, right? You don't want to waste any more time. You want to take him to the operation room and perform a emergency exploratory laparotomy, so that in the operation room, you know which organ is bleeding and try to ligate it. So here we go for a emergency exploratory laparotomy. And this is a very important flowchart that I want all of you to remember. Whether the patient is stable or unstable, the first investigation has to be fast. Okay, the first investigation that you do has to be an ultrasound or fast. To know whether you go for CECT or whether you go for emergency laparotomy, check for the patient's vitals. If the patient is stable, go for a CECT. If the patient is unstable, right? Go for emergency laparotomy. So in our case, we know that the blood pressure is less, right? The patient is not becoming stable even after giving IV fluids. So the answer should be what? Exploratory laparotomy. Exploratory laparotomy. I hope you got this correct. Next one. ये थोड़ा सा controversial था. I got different students giving different opinions on this radiograph, but let me see what all you answer. What do you think? Diagnosis of the condition given on the given X-ray. So was the image something similar like this? Was the image like this? Anterior dislocation of hip, posterior dislocation of hip, fracture neck of femur, Perthes disease. Was the image right? कैसा था image? Was it like this one or was it like this two? So don't answer based upon what you answered in the exam. Okay, what came on the exam? 1 or 2? What do you think? What do you think was the image that appeared on the exam? Was it 1 or was it 2? So it was posterior dislocation. Okay, so it was mostly 2. Fine. So I'll tell you both, right? Depending on what came on the exam, you decide it. So basically in Perthes disease, right, which is idiopathic osteonecrosis of the head of the femur that occurs especially in young patients, right, young boys, you will see that the epiphysis is irregular and collapsed, right? Irregular collapsed epiphysis with some V-shaped lucencies that you see on the superolateral aspect of the head of the femur. So this would how the Perthes disease would be, right? So collapsed, and the height of the epiphysis of the femur is collapsed, decreased height, and also you see this superolateral side, you see this V-shaped lucencies. What do you call this thing? This is called as Gage's sign, right? So Gage's sign. So I'll show you the images again. So that is the Gage's sign, where you have this V-shaped lucency on the superolateral aspect of the head of the femur. Here also you can see this irregular fragmented epiphysis, collapsed epiphysis, right? So this is your Perthes disease. So this is how you have your Perthes disease. So many people are actually answering again the same thing here. 1 and 2 both are coming in the same options. So I keep it to you. आप लोग ने exam में देखा था. So if you have seen something like that, that is Perthes. But if you see that the shaft of the femur is appearing adducted, right? So you can see the image, shaft of the femur is appearing adducted. You are not even seeing the lesser trochanter. That means it is internally rotated, right? The lesser trochanter is not visible. That means it is internally rotated. So whenever we have a flexion, adduction, and internal rotation, right? What is this? This is FADIP, right? So we learned this in our classes. So this is FADIP. P stands for what? Posterior dislocation. And you will see the head usually going above the acetabulum in posterior dislocations and below the acetabulum in anterior dislocations. So this is classic posterior dislocation, flexion, adduction, internal rotation. So I hope what you have answered came on the exam, but that is what the thing is. 2 different students groups are answering that 2 different ways. So I hope you got it right in the examination. Next. So Perthes, few words about Perthes. It is avascular necrosis of the head of the femur, more younger children, young boys usually, right? And this is mostly painless and self-resolving. 2 important X-ray findings that I want you to remember, right? One is your Gage's sign, which is a V-shaped lucency that you see on the superolateral aspect of the head of the femur. And sagging rope sign is, this is Gage's sign, right? You can see the V-shaped lucency on the superolateral aspect. And sagging rope sign is a sclerotic line that you see hanging around the head of the femur. So around the neck of the femur. So around the neck of the femur, you see the sclerotic line. So that is called as a sagging rope sign. So sagging rope sign and the Gage's sign, like along with the collapsed and irregular epiphysis, that would be Perthes disease. And what do you think is this? This is anterior dislocation or posterior dislocation? What do you think is this image? Anterior hoga ya posterior hoga? How is the head of the femur? Is above the acetabulum. This is lesser trochanter. Are you able to see the lesser trochanter? No. So what is this? Internally rotated, right? Agar external rotate hota, if it is external rotated, you would see the lesser trochanter more obvious. Here you are not seeing the lesser trochanter also. You are seeing an adduction as well as internal rotation. So this is also again posterior hip dislocation, And what is this image? Standard image. You should not miss that. This is fracture neck of femur, right? Fracture neck of femur. And where do you see that when you draw a line from the superior aspect of the neck of the femur, it should normally cross the epiphysis of the head of the femur. So when you draw a line from the superior aspect of the neck of the femur, it should normally cross the epiphysis of the femur. That is what happens in normal appearances. But if it does not cross, that is called as Trithovan sign. So you can see that the line is not crossing the epiphysis. It's not going through the epiphysis. So this is called Trithovan sign, feature of slipped capitofemoral epiphysis. And this line that you draw from the superior border of the neck of the femur, this is called as your Klein's line. So when you are given a hip image, you could be given simple X-ray agar diya gaya without history and all of that. So you have to look at all of these things. One is Perthes, where you see a collapsed and fragmented epiphysis, the Gaggy's sign and a sagging rope sign may be given. Coming to your posterior dislocation of hip or anterior dislocation of hip, that is simple, FADIP and FABIA, right? FADIP for posterior dislocation, flexion, adduction, internal rotation with posterior dislocation. FABIA for anterior dislocation, flexion, abduction and external rotation. Whenever you have adduction, there is limb shortening, right? And whenever there is abduction, this will be limb lengthening, right? So you should know these things. Then fracture neck, you should be able to identify the fracture neck. Again, important thing that you have in osteoporotic females also, right? Trivial trauma can cause this fracture neck of femur. And slipped capitofemoral epiphysis, you draw a line from the superior border of the neck of the femur, and it should normally cross the epiphysis. If it is not crossing the epiphysis, that is called as a slipped capitofemoral epiphysis. It is actually the metaphysis that overgrows in whenever at times of puberty, excess growth hormones, some endocrine problems, right? So the metaphysis actually overgrows and the epiphysis appears to be slipped. Even though you're calling slipped capitofemoral epiphysis, it is not the slip of the epiphysis, it is the overgrowth of the metaphysis that occurs because of puberty or some hormonal changes, excess growth hormone or some endocrine problems in the patient, right? So this is also common in males, slipped capitofemoral epiphysis. Next, coming to one option was acetabular fracture too. Okay, acetabular fracture was there in that option. Okay, but I hope that was not the thing, but it depends upon what was there on the exam. And image to nahi rakha hai, but yeah, one option was acetabular fracture. Okay. So let's see the next question. A female who was taking NSAIDs for long period for her arthritis presented to the emergency with severe pain abdomen. So there is a long history of NSAID use, and abdominal radiograph is given, and what is the likely diagnosis? Pericardial effusion, pneumothorax, peptic ulcer, perforation of peptic ulcers. Now, long-term NSAIDs, right, can cause peptic ulcers, but the abdominal radiograph clearly showed, right, the air under diaphragm, especially under right dome of diaphragm. This is classic of a hollow viscous perforation. So the better answer यहाँ पे क्या होना है? Perforation of peptic ulcers. So because he is having abdominal pain and the radiograph is showing air under diaphragm. So if you just have peptic ulcer disease, you would not see air under diaphragm. To see air under diaphragm, you should have a hollow viscous perforation. So it must be a perforation of peptic ulcer. So that is a better answer if both options were given. Some students have told both options tha, sir, ek baar peptic ulcer disease bhi tha, ek perforation bhi tha. So if they are given both thing, I hope you have selected it carefully, perforation of peptic ulcers. Is that clear? Serum amylase was normal here. Okay. So that means that rules out the pancreatitis part and all, right? Sure. Let's go to the next one. Simple one. Okay, this is standard. ये तो emergencies तो कोई भी miss नहीं करना है. Pneumothorax, pneumoperitoneum, pneumocephalus, right? The hematomas, epidural hematomas. I hope none of you will, miss out on that. You have to be very strong on your emergencies. Next. Another image. Cannonball opacities on the given chest X-ray indicate. So very large cannonball-like opacities diffusely in the both lungs. What is this suggestive of? This is suggestive of pulmonary metastasis. What is the most common cause of such cannonball metastasis? Cannonball metastasis, most commonly they occur due to RCC, if it is a male smoker, and choriocarcinomas, right? Especially in females, it can be choriocarcinomas. So this is pulmonary metastasis. Do not confuse with a primary lung cancer or fungus ball. Okay, so those are different. The pulmonary metastasis, they produce this cannonball opacities, common in patients with RCCs as well as with choriocarcinomas. Next, I hope all of you have got this right. ये तो question दे देते हैं आप लोग को, right? So you get these questions as gifts. I hope you don't miss out on that. A 20-year-old male patient presents with pain and swelling around the wrist joint. There is no history of injury, and X-ray taken from the patient is given below. What is the likely diagnosis? Is it osteosarcoma, rickets, Colles, and giant cell tumor? So you're given a radiograph at the wrist, which is showing a soap bubble-like lytic lesion. So bubble-lytic lesion involving the distal radius, right? And it is very subarticular, just adjacent the joint space. So it is subarticular. And is it involving the epiphysis or metaphysis? It is involving the epiphysis and extending into the metaphysis. So basically epiphyseal lesion. So epiphyseal lesion, subarticular, extending from the epiphysis into the metaphysis, and the most common bone tumor involving the distal end of the radius is your giant cell tumor, right? So, or osteoclastoma. You also call it osteoclastoma. I hope you got this right? So osteoclastoma. Remember, GCT or osteoclastoma is the most common bone tumor involving distal radius. So they gave the image of the distal radius. So GCT is the most common bone tumor involving distal radius. And the most common site is lower end of femur. So lower end of femur. So differentiate these two things. The most common site of the GCT or osteoclastoma is lower end of femur, but the most common bone tumor that occurs at the distal radius is also GCT. Next thing. An important thing to know is to know whether the patient's skeleton is matured or not. Either they'll give you the age group, which will be above 20 years, or even if they don't give the age group, look at the radiograph, right? So if the growth plate is not seen, the growth plate appears fused, right? So this is a mature skeleton. The growth plates appear fused. This is mature skeleton. GCT occurs in mature skeleton only. Yeah, generally above 20 years, between 20 to 40 years, you see this GCT, right? Usually above 20 years, you'll have this between 20 to 40 years where the skeleton is mature. So you can see the growth plates, they're all fused. So this is a mature skeleton. And you see this bubble-lytic lesion, subarticular in the epiphysis, extended to the metaphysis. This is all GCT. Next. Abhi ye kya hai? What is this thing? Do you think is it GCT only, or right? It is also at the distal radius, or what comes to your mind? Imagine they change the question in your future exams, okay, or for the future aspirants. What do you think this could be? Is it in the epiphysis or is it in the metaphysis? First of all, is it fused growth plate or unfused growth plate? Look at the growth plate and tell me, is it fused growth plate or unfused growth plate? Kya lag raha hai aapko? Is it fused or unfused? So this is unfused growth plate. And that means, is it mature skeleton or immature skeleton? This is immature skeleton. Immature skeleton. That means it is usually less than 20 years, less than 20 years of age group. And where is the location? Is it in the epiphysis, right? So the epiphysis is not involved. It is in the metaphysis. So you're seeing it in the metaphysis. So unfused growth plate, immature skeleton in the metaphysis, causing that cortical ballooning, like an aneurysm, like how you have aortic aneurysm, right? So like an aneurysm, it is causing cortical ballooning. What is this? This is ABC, aneurysmal bone cyst, aneurysmal bone cyst, aneurysmal bone cyst, right? So it is very important. Just because you are seeing a lytic lesion, don't always jump to GCT. Mostly it will be GCT, but always look at the clues given. Age group that is given, whether the growth plate is fused or not, is it a mature skeleton or immature skeleton, is it epiphyseal, subarticular, or is it metaphyseal, and you should be able to differentiate ABC from a GCT. Important to differentiate that. Next thing. Now look at this lesion. Now what do you think is this lesion which is seen in the epiphysis? This is in the epiphysis. And this is not eccentric. This is this is not completely towards one side. It is not eccentric completely. And look at the growth plate. The growth plate is also not fused, unfused growth plate. So this is also young patient. Epiphyseal lesion. This is chondroblastoma. So when you are given epiphyseal lesions, think of two things. Epiphyseal lesions. One is GCT, one is chondroblastoma. That is Codman's tumor. Right. How do you differentiate it? GCT is mature skeleton, more than 20 years, mature skeleton, right? This is a immature skeleton, young patient, younger than 20 years, right? And both of them are in the epiphysis. Can you tell me what are diaphyseal lesions? What are the diaphyseal lesions? Diaphyseal lesions, AEO, double O, right? Admantinoma, also called as ameloblastoma, right? Ameloblastoma, especially in the mandible, or admantinomas, right? Ewing sarcoma. And why did I write this O like this? It is not osteochondroma, it is not osteoclastoma, this is osteoid osteoma. And anything else you tell me, whether it is osteosarcoma, right, whether it is enchondroma, whether it is simple bone cyst, aneurysmal bone cyst, anything else will be what? Metaphyseal. So GCT and chondroblastoma, this is epiphysis, AEO, these are diaphysis, and everything else you better write it as metaphyseal lesion, right? It was Perthes disease, there was fracture neck of femur 100%. Okay, Harrison, okay, I hope whatever you have answered is right, but again, this is student recall, so I have kept it as Perthes, but hope, most of you have got right. That would what I expect, right? So instead of me being right, I hope you be right on the day of exam. Anyways, next thing. Look at this next question here. A 60-year-old male presented with multiple bone pains, anemia. His calcium levels were elevated. Albumin globulin ratio is deranged with elevated globulin. Benz-Jones proteins are seen. A skull radiograph is given. So very standard. This cannot be more simple, right? So this is multiple myeloma, right? So clinical features of CRAB were given. What is CRAB? Hypercalcemia, right? Renal failure, anemia, bone pains. All of that is there. And you are given that M spike or M spike where you have excess IgG or immunoglobulins. And what is the skull radiograph showing? Multiple raindrop appearance, right? So raindrop skull, where you see this multiple lucencies. So this is classic multiple myeloma, elderly patient. This is seen in elderly patients. Clear, guys? So this is simple. I hope all of you have got it right. So this was multiple. This time the exam, I hope you'll have a good pass percentage also, much comparable and better than the last exam. I hope so, because the questions were pretty much on the standard part, and standard, they didn't go for any fancy stuff. Some questions will be there, but they don't decide your result. So don't worry about 1 or 2 questions here and there, but mostly you'll have good results. All of you have studied and put some effort. I hope the results will be favorable. Okay, next. What is this? Identify the marked bone on the given radiograph. Did you look at this? What did you answer? So this bone, which is appearing like a navy, okay, like a boat, navy boat. So this boat shaped bone is what is called as your navicular bone. On the medial side you have it. So it's important to look at the carpal bones and the metacarpal bones, right, carefully. The tarsal bones, the metacarpals, the carpal bones, the metacarpals, and how to label them up. Especially your carpal bones and tarsal bones, you learn your labeling properly, right? So she looks too pretty, try to catch her for your carpal bones, and your bones in the foot also. So let me just help you out with it. So the bone which is boat shaped on the medial side is navicular, and the one which is on the lateral side is your cuboid. And anterior to the navicular, you see the 3 cuneiforms, the medial, intermediate, and the lateral cuneiforms. And the talus articulates with the tibia and fibula to form the ankle joint, and it articulates with the calcaneus to form the subtalar joint. So you know these basic anatomy, right? So navicular on the medial side, cuboid on the lateral side, and in front of the navicular you have the 3 cuneiforms. So let us look at them on the radiographs now. So you can see here, this is the tibia, this is the fibula, and they are articulating with the talus to form the ankle joint. And this talus articulates with the calcaneus below to form the subtalar joint. And this bone anterior to the talus, right, on the medial side, this is your navicular bone, which is appearing boat shaped. And in front of the navicular bone, you are seeing the 3 cuneiforms. So obviously this will be the medial side, so the medial cuneiform, intermediate, and the lateral cuneiform. And this is the lateral side, and this bone on the lateral side is your cuboid, which is articulating with the calcaneus. So navicular on the medial side, cuboid on the lateral side. So based on what was marked on the exam, but most students said It was navicular. So I hope you got it right. Navy shaped bone. Next, even lateral radiograph can be asked. So have an idea for your future exams. So this is how the calcaneus, the heel, right? So this is the talus, right? Interiorly, you have the navicular. Then anterior to navicular, you have the three cuneiform bones, right? The medial, the intermediate, and the lateral cuneiforms. So with that information, now you tell me, what is A? What do you think is A? What do you think is A, guys? Do you think it is cuboid, calcaneus, navicular, cuneiforms? What is this? A. Try. Let me see your chat. What is A? No answers. Waiting for your comments. Chalo, B bata do. Okay. B bata do pehle. B bata do. What is B looking like? What is B? Tell me B first. Look at B. Kaisa dikh raha hai? Which is appearing, look at all the numbers and say me which is appearing like boat shaped. Which is appearing like boat shaped in all of them. A, B, C, D, E, F. Which is appearing boat shaped? B, right? So this is navicular. Navicular. Yeah, medial side, lateral side. Okay, you should be able to and identify that. No, it's boat shaped. Abhi aur kaun sa dikh raha hai aapko boat shaped? So this is navicular. तो आपको पता है this is medial side and this would be your cuneiforms. Navicular, anterior to navicular, what do you see? The cuneiforms. Cuneiforms. Right. And the C is talus. F is calcaneus. And what is anterior to calcaneus? E is cuboid. So that is how you have your bones there. And D is also a cuneiform. D is also the cuneiform, the lateral cuneiforms. Right. So that is how you have your tarsal bones that are seen on a foot radiograph. Are you clear? Yeah. Chalo, E is cuboid. All of you got it right. So will you manage that thing? Will you manage it on the radiograph, right? So next time, chalo, let us try on this image. So what do you think is this bone that I am marking with the green mark now? What is this one? What do you think is this now? Ye kya hai? What I have marked you with the green pen. This is which cuneiform? Lateral, medial. Which cuneiform? Which cuneiform do you think is this? This is your medial cuneiform, right? Medial cuneiform. So thoda time spend karo. It's not difficult also. First you identify this boat shaped bone. You know navicular. It is on the medial side. And then you can know medial, intermediate, lateral, cuboid and all of that bones, right? So you should be able to mark them properly. Let's go forward, guys. Okay. Did you see this question like this? Popcorn appearance in the lungs? Right? We learn popcorn appearance on the chest x-ray, on mammo and all. Kahan pe hota hai? Popcorn appearance on the in the lungs. This is case of pulmonary hamartoma, right? So popcorn appearance in the lungs is case of pulmonary hamartoma. Popcorn appearance in the breast, okay, on mammography, they would be fibroadenoma, right? So you need to learn this list. Popcorn appearance on mammography or in the breast pucha gaya, then answer should be fibroadenoma. But if they ask you on the chest x-ray, this is pulmonary hamartoma. And where do you see the popcorn appearance on MRI brain? MRI brain kahan pe hota hai? Do you remember popcorn appearance on MRI brain? This is feature of cavernous angioma. So popcorn appearance on MRI brain is cavernous angioma. And can you ask you on the iliac bone or on the flat bones, popcorn appearance on iliac bone? Can you think of any condition or any tumor which produces popcorn appearance on the iliac bone or flat bones? A tumor of the flat bone generally. Where do you see this? This is chondrosarcoma. So have brief ideas about this popcorn. And if you are given in the pelvic radiograph in a postmenopausal female with chronic pelvic pain, which was asked in your last time's FMGE exam, postmenopausal female, chronic vesical calculi. So they will usually be lamellated appearance or a jackstone appearance. The lamellated appearance is more common, and sometimes when you have a jackstone calculus, you'll have that kind of appearance. But a popcorn appearance, irregular popcorn appearance would be a feature of a calcified fibroid. So this was asked in your previous FMGE exam. So similar popcorn appearance was asked here. Popcorn appearance in the lung is pulmonary hamartoma. Pulmonary hamartoma. Okay. Next. So this is how we have the chest radiograph in the lung showing a popcorn appearance. So this is pulmonary hamartoma. Pulmonary hamartoma. I hope all of you have got this right. Very standard questions, right? I don't expect, if somebody has put little effort to miss out on this, we're asked any standard questions. Okay, pulmonary hamartoma. This is mammography showing popcorn appearance. This is fibroadenoma, right? So this is fibroadenoma. Involuting fibroadenomas, they have this popcorn-like appearance. And this is MRI brain showing this irregular popcorn-like vessels, vascular lesion. This is cavernous angioma. Cavernous angioma. And this is popcorn appearance on the iliac bone. This is a chondrosarcoma. Chondrosarcoma. So remember all these popcorn appearances, right? Now another very easy question, I would say. Identify the given ultrasound image. I don't know if you gave you any history, but ultrasound image showing a enlarged uterus with multiple grape-like cystic areas within. What was this? Snowstorm appearance. So this is classic snowstorm appearance. And this snowstorm appearance is feature of Hydatidiform mole, right? So Hydatidiform molar pregnancy, right? Fibroadenoma. Remember, the question was asked in the lungs. So they didn't say even chest X-ray. The question was very clearly on the lungs. So in the lungs, obviously, your answer should be pulmonary hamartoma. And better go for chest X-ray, pulmonary hamartoma. Fibroadenomas picked up more on mammographies rather than on chest X-rays. Okay, so the clarity of the image is not good on the chest X-ray to look at fibroadenomas, right? You need a mammography image for them. So in the lung or chest X-ray, better answer is pulmonary hamartoma. Go with pulmonary hamartoma. Next. Then this is what a snowstorm appearance is. Lot of enlarged uterus with multiple hyperechoic grape-like cystic areas, right? This is suggestive of a molar pregnancies. Another question, patient with severe headache and they gave a non-contrast CT, and on this non-contrast CT you see hyperdensities in the sulcal spaces, right? In the sylvian fissure on either side, the sulcal spaces, the basal cisterns around the midbrain and the basal cisterns. What is all of this? This is, they gave all the options of subdural, subarachnoid, like that. This is classic. Yes, Adarsh, Mozahid, right? So all of you are correct. So this is acute subarachnoid hemorrhage. When you see hyperdense areas, it is acute subarachnoid hemorrhage. Acute subarachnoid hemorrhage. And if it was lemon shaped, biconvex like this, what is this? What is this? This is epidural hematoma. And if it is banana shaped, which is crossing sutures but not crossing midline, concavo-convex, crescentric, this is how you would have your subdural hematoma. This is how the subdural hematoma would be. So epidural hematoma, biconvex, lentiform. Subdural hematoma, banana shape, right? Concavo-convex, crescentric, right? And your subdural hematomas would be crescentric, and subarachnoid hemorrhage would be hyperdensities in sulcal spaces, sylvian fissures, basal cisterns. You learn a lot. Okay, we do in detail in neuroradiology part where we discuss everything about these things in the CT scan images also, right? Okay, let's come to the next one. A female patient had, I think, cervical cancer, or some students were saying bladder cancers, underwent radiotherapy. Which is the most radiosensitive organ in the among the following? Bladder, ovary, urethra, vagina. What did you answer for this? Most radiosensitive organ. Remember, what is the most radiosensitive tissue? Most radiosensitive tissue in the body. Most radiosensitive tissue in the body is your bone marrow. It is your bone marrow. And what is the most radio-resistant tissue of the body? Most radio-resistant tissue of the body is the one which is very well differentiated, non-dividing. That is your nervous tissue, CNS, or the nervous tissue. But if they ask you most radiosensitive organ which has multiple tissues, right? So that would be your gonads, especially your testes, more than ovaries. So gonads, testes, and ovaries would be radio sensitive. And what a radio resistant organ? What is the most radio resistant organ? It is your vagina with the stratified squamous epithelium around it, right? Vagina is a radio resistant organ. So answer here should be the ovaries, right? Ovaries. So clear cut. In radiotherapies, you learn all of this very standard. they asked you the same thing, and most radiosensitive organ while performing radiotherapy would be your ovaries or your gonads, which has all that stem cells, dividing cells, right? So law of Burgoni we study, where you have multiple undifferentiated cells, dividing cells, they will be radio sensitive, and resting cells which are well differentiated are radio resistant. Law of Burgoni, right? So from the law of Burgoni you get all of this information, and it says that undifferentiated cells, blast cells, undifferentiated with high mitotic activity like the bone marrow, like the gonads, they will be radio sensitive. That is law of Burgoni. Okay, now this is also a little controversial. I hope you got it right on the exam, but different because you have to get a correct recall for me to be able to tell you. But this was, some of the students said that the image was like this, where what did you answer for this? Just tell me, what is this image first of all? Is it barium meal follow through, enterography, CT enteroclysis, or MR enteroclysis? What did you answer for this? What did you answer for this? Barium meal follow through, enterography, CT enteroclysis, or MR enteroclysis? How is the appearance? Did you get any answers? I'm not seeing the chat. I can't get the chat. What happened? I can't see the chat. I think all okay. Okay, so this image where you can see that these small bowel loops are distended, there is a neutral contrast or a negative contrast that can be given, and you cause luminal distension here. You cause a small bowel distension so that you can see the mucosal lining better. So the important feature of performing an enteroclysis is we use a NJ tube, nasojejunal tube, and then put methyl cellulose or water to distend the small bowel loops, and you can see the mucosa better. So you use methyl cellulose after using an NJ tube, right? So that is what is enteroclysis. What is an enteroclysis? You are putting the NJ tube. So it's an invasive procedure. When you put a nasojejunal tube, the tube is made to pass across the ligament of Treats, that is the junction between duodenum and jejunum. So you pass the NJ tube beyond the ligament of Treats, and then you inject the methyl cellulose or water, okay, which will cause luminal distension and help us to look at the mucosa of the small bowel better. So that is enteroclysis. Enterography is basically giving oral contrast. When you give orally only, that is enterography, and when you give it with NJ tube, invasive, that is your enteroclysis. And the barium meal follow through is a simple barium study that we have for small bowel, right? So this is your, if the bones are black, so the bones are black, this is MR enteroclysis, and if the bones appear white, that is CT enteroclysis. Bones appear white, that is CT enteroclysis. Can you hear me, guys? I think there is some, I can't see this happening. Are you able to hear me clearly? I think some network issue. This is your MR enteroclysis. So you can see here the bones appear black, all the bones appear black. Is it fine? Okay, so the bones are appearing black. So you can see the fluid, the luminal fluid, whether it is T1 or whether it is T2, right? The fluid will appear dark on T1 and white on T2. So this is how you have your MR enteroclysis. So this is the chat part. So this is how you have your MR enteroclysis, and this is a very good investigation to look at small bowel mucosal lesions, right? So especially to look at patients of Crohn's disease or any kind of malabsorption syndromes, we like to look at the mucosa better. So looking at the mucosa, enteroclysis would be better. So, and based upon how the bones are appearing, you answer it as MR enteroclysis or a CT enteroclysis. If you can see the pelvic bone, the ribs white, right? So the ribs are white, the pelvic bones are white. Sometimes it may be shown the vertebra. So all of this is your CT enteroclysis. So enterography is a X-ray procedure. Enterography is basically a X-ray procedure where you are given an oral contrast and then you are looking at the images. But here this is a NJ tube that is inserted beyond the duodenum into the jejunum. NJ tube, nasojejunal tube is given, and then you give a contrast and study, that is CT enteroclysis. CT enteroclysis. What was the thing that was given in the exam? What was it, CT, or do you think it was MR? कैसा था? I have kept both images here, CT enteroclysis or MR enteroclysis. Ribs were white. Adarsh's ribs were white. So if the bones were white, it is CT enteroclysis, guys. Okay, so if the question had the bones white, the answer is CT enteroclysis. Next, you tell me, what is this? CT or MR? Look at the image and tell me, what is it, CT or MR? So everybody is saying it is CT, so I agree with you guys. So it must have been CT in the exam. But can you answer this thing? Can you answer this thing now? CT or MR? So this is again, the signals are changing with T1, T2 weighted imaging, as well as the bones are appearing dark here. So this is MR, MR enteroclysis, MR enteroclysis. And this is your CT enteroclysis, CT enteroclysis, right? So this is CT enteroclysis. I hope you got it right. And what is this? What is this image? What do you think is this image? Is it CT enteroclysis or is it MR enteroclysis, barium meal follow through? What is this? Here you are seeing the stomach and the duodenum, right? So the first part of the duodenum and the C-shaped loop of duodenum. So when you can see the stomach and duodenum, this is your barium meal only barium meal. And if you are able to see the jejunal loops and the ileal loops, right? This is barium meal follow through, The jejunal loops, jejunum appears feathery. It appears completely feathery, right? A lot of valvulae conniventes and appears very feathery. Whereas ileum is featureless. Ileum does not have that kind of valvulae conniventes. It appears featureless. So ileum is featureless. So you need to understand what was given, barium meal or barium meal follow through, or is it CT enteroclysis or a MR enteroclysis. Next one. This is also a very standard image that I teach you in, organic ultrasound also. A female with infertility, and the history was also sufficient. A female with infertility, an ultrasound image was given which showed bilateral ovaries to be enlarged, and large ovaries are there. So when you are seeing bilateral involvement, when you are seeing large cysts, right, with thin central spoke wheel stroma, like stroma, with a classic history of infertility treatment, injections of HCG given into the female, all of this is suggestive of ovarian hyperstimulation syndrome. And in comparison to PCOD, let me show you the images. If I compare PCOD from ovarian hyperstimulation syndrome, right? In PCOD, the stroma is thick. There is thick echogenic stroma. The underlying cause is excess androgens, and these androgens are coming from the stroma. So there is a thick echogenic stroma. And you have small cysts, small peripheral cysts. Even without the history, by looking at the image, you should be able to diagnose whether it was PCOD given to you or is it ovarian hyperstimulation syndrome. Small peripheral cysts, which are 2 to 9 mm, never a dominant follicle, never be more than 10 mm, right? So it will never be a dominant follicle there. Very small peripheral cyst giving that string of pearl appearance and all. And this can be unilateral. Okay, even it can be unilateral to call it PCOS, right? So ovarian volume. What is ovarian volume? Ovarian volume more than 10 ml or 10 cc, and follicles more than 20 according to new international criteria, more than 20. So all of this is PCOD. Whereas ovarian hyperstimulation syndrome, this is bilateral usually, because obviously you are giving injections of HCG. It will stimulate both the ovaries, and you will have this large cyst, not small cyst, large cyst, and a thin stroma, right? Thin spoke wheel like stroma, and this stimulated ovaries, they release loss of vasoactive peptides, and these vasoactive peptides cause capillary leaks. They cause, leakage into the third spaces. So third space collections will occur. So you may be given ascites, you may be given pleural effusions, hemoconcentration, and fatal also sometimes. pleural effusions, ascites, all of this can be there, right? And you can also have pericardial effusions, hemoconcentration, and death also. So that is how you have ovarian hyperstimulation syndrome, and this will be usually a patient who is undergoing infertility treatment. Infertility HCG injections would be given in the patient, causing all of this. So that is how you have to differentiate. And by the way, can you tell me what is the ovarian cyst which has this thin fibrin strands giving that fishnet appearance or network like lacy appearance? Fishnet or lacy appearance or network like appearance. Can you think of anything like that? Can you see this thin strands, fibrin strands there? What do you think is this? This is hemorrhagic ovarian cyst. Hemorrhagic ovarian cyst. Ovarian cyst. What is this image? What is this image? What is this image where you see ground glass appearance on ultrasound in the ovarian cyst? Because of a lot of debris inside, okay, lot of debris inside. In endometrioma or chocolate cyst, you have this ground glass appearance. So be careful with the images. Either it is a hemorrhagic ovarian cyst, or endometrioid cyst, or a chocolate cyst. Is it a polycystic ovarian disease or a ovarian hyperstimulation syndrome? So I hope you will manage that with the images in the future. Next one. Luckily, we got one question on COVID-19 this time, and it was pretty much straightforward. If you have seen any kind of COVID-19 patient, right, any description of any radiology image, you must have got this right. So they said a chest x-ray from a patient of COVID-19. I'm not sure if the x-ray was given, but they said a patient of COVID-19 x-ray is there, and what is the finding? So obviously you will see this bilateral peripheral ground glass opacities. Okay, bilateral peripheral ground glass opacities was mentioned. Ground glass opacities. So that is the classic finding that you see in patients with COVID-19, right? You don't see apical cavitations, calcifications, nodules in COVID-19, right? So these are not seen in COVID-19. Okay, these are more of tuberculosis, nodules, between bud opacities, centrilobular nodules, cavitations, right? Calcifications, lymphadenopathy. They're all not seen in COVID-19. In COVID-19, you have classic ground glass opacity. So x-ray was not given, they just asked what is the finding. So answer should be bilateral peripheral ground glass opacities, ground glass opacities. So look at the echoradiograph. Bilaterally, peripherally, you are seeing this multifocal, multiple, bilateral, peripheral, right, ground glass opacities and consolidations. This is how a classic COVID-19 x-ray appears. Remember, first line investigation that you have to do in patients of COVID-19 is not CT scan, is your chest radiograph. Chest radiograph. It has to be your first thing. And don't do chest x-ray or any imaging. Imaging, please remember, imaging is not required. Imaging not required for screening, for diagnosis. Don't use screening for diagnosis in no CT, no x-ray. Don't use x-ray, CT scans for screening or diagnosis of COVID-19. Are we clear? So don't use this for screening or diagnosis of COVID-19. Do not use imaging in mild patients. Do not use imaging in the sense no x-ray, no CT also. Do not use imaging in confirmed COVID-19 also. Confirmed COVID-19 with mild symptoms. So only use it when you are feeling that the patient may have respiratory deterioration. Role of imaging is only in patients who are suspected to have respiratory deterioration. Elderly patient, known asthmatic, immunocompromised patients, or the patient is not improving, he is having moderate to severe symptoms, and in that patient get an x-ray done and observe him. If he is worsening, then we go for a CT to look for what could be the cause, ARDS, pneumomediastinums and other things. But as such, don't use it routinely for screening or diagnosis of COVID-19. Do not use it in confirmed RT-PCR positive COVID-19 patients who is just having mild symptoms. Keep this in mind. And the first line investigation should be a chest radiograph. And what does it show? Bilateral peripheral involvement of the lungs, showing ground glass opacities and multifocal consolidations. Next thing. And what is the difference between a ground glass appearance and a consolidation? Ground glass means where you have haziness in the lungs, which you can see the vascular markings through it. So through the haziness, through the opacity, if you are able to see the vascular markings, that is called as a ground glass appearance. And if you are not able to see the vascular markings, but you can see some air bronchograms, That is what a consolidation is. So in consolidations, you will not see vascular markings, but you can see air bronchograms. So this is what a consolidation is. And you can see here bilateral, peripheral, rounded, ground glass opacities that you are seeing. All of this is your COVID-19, classic COVID-19, multifocal, and their peripheral ground glass opacities and consolidations. You can see another coronal section here showing this bilateral, peripheral ground glass opacities. So these are your consolidations. These are consolidations. You are not seeing ground glass opacities. You are seeing consolidations with air bronchogram. Okay. And what are the typical findings? What are the other typical findings that you can expect in COVID-19? More than halo sign, we generally see a reverse halo sign. In reverse halo sign, you see peripheral consolidation with central ground glassing. So you see peripheral consolidation with central ground glassing. This is also a typical finding that you can see, especially in healing stages of COVID-19. And you may see thickening of the interlobar and interlobular septa, and that is called as crazy pavementing. So I want you to remember what are the typical findings, what are things you can expect in COVID-19 patients, what are the typical radiological findings in COVID-19. The important one, the most common one that you see are the bilateral, peripheral, multifocal ground glass opacities, right? So multifocal ground glass opacities. And then you can have thickening of the interlobar and interlobular septa in these ground glass opacities producing crazy pavementing. You can have a crazy pavementing where you have thickening of the septa like this, right? So you have this thickening of the septa. This is what a crazy pavement is. So you may have a crazy pavementing once you have the thickening of the interlobar and interlobular septa in the GGO. Then you may have multifocal consolidation, not a lobar consolidation, multifocal consolidations. Multifocal consolidations, right? In COVID-19, do remember all of this, okay? For all your upcoming exams, these are high yield content. So bilateral, peripheral, multifocal ground glass opacities, crazy pavementing, multifocal consolidation, not lobar consolidation. Lobar consolidation will be bacterial pneumonias. Multifocal consolidations, think of COVID-19s. And you may also have this reverse halo, especially in the healing stages of COVID, right? Reverse halo sign, right? And do remember some atypical findings, what are not seen in COVID-19. So these are typical findings, and what are not seen. What are atypical findings, which usually you don't see. Atypical findings. You will never see cavitations, right? You will never see pleural effusions or lymphadenopathies usually, okay? These are not routinely seen, okay? Lymphadenopathies and stuff. And you will not see any nodules. You will not see nodules. These are considered to be atypical findings. These are all features of TB, right? And also remember, you don't see lobar consolidation. Lobar consolidations are bacterial. These are bacterial. Multifocal consolidations is COVID-19. Lobar consolidations are generally bacterial pneumonias. And it is good now to differentiate TB in our, which is common in our country, from COVID-19. These are very distinct things, right? So easy to pick or differentiate COVID-19 from tuberculosis. So they asked you typical finding, and they asked you very straightforward, but do remember both what are typical and what are atypical findings in COVID-19. Are you clear? Is this clear, guys? Right, manageable this one. So let's go forward now. Okay, so those were the important questions. One more question was asked. I don't actually recollect it, but they were saying that there was a child, an infant, who was having difficulty in passing meconium, and what is the next step of investigation. So basically they try to give you a history of Hirschsprung's disease, and in Hirschsprung's disease, obviously you'll go for a barium enema, which would show the altered rectosigmoid ratio. There is constricted part, the diseased part, where the ganglion have not come. Sorry, there is colonic aganglionosis, and this dilated part is normal part, and this constricted part is the pathological part. And remember, in Hirschsprung's disease, the rectosigmoid ratio, right? Normally rectum is more in caliber than sigmoid colon. Normally the rectosigmoid ratio, normal rectosigmoid ratio is more than 1. But the rectosigmoid ratio, if it is less than 1, think of Hirschsprung's disease. So either the barium enema image like this can be given, where you see a constricted portion and dilated part. The dilated part is a normal part, and the constricted part is a pathological part, where you don't have the colonic aganglionosis. This is Hirschsprung's disease. And you can be asked about its association also, that is Down's syndrome. Okay, Down's. To remember, Down's in GIT, duodenal atresia, as well as Hirschsprung, right? Commonly tested. and they asked you what is to be done. So barium enema and rectal manometry, right? Barium enema and a rectal manometry should be done. In Hirschsprung's, this is duodenal atresia, and in Hirschsprung's, do remember these conditions in relation to Down syndrome. So I hope you had a good exam. Don't worry about few mistakes here and there. We don't need 300, right? You will still do good. So don't always look at the negative side of it. If you have done well, you have answered it most of the questions right, so you should be happy and take a good break. This is very rare times you get such a small breaks where you're free from everything else, no hospital work, no studies, nothing. So enjoy this time and be positive. Hopefully you'll have good results. And if you're aspiring for future exams, my advice would be to start early. The concepts tested are very basics, right? But they are giving it with a clinical integration, so you need to understand. Don't just go for one-liners or random, memorization of the thing. Understand the topic. Very simple, basic questions are there. Very doable exam. Start early and you should do good. All the best for all the people who have attempted the exam, and I hope you all come out with flying colors, and I get to hear from you after the results. And hope you all have a happy new year in the future, right? So hope December 31st, around 31st, they said the results would be. So I hope in the coming year, there'll be more positive things and more good things coming your way. All the best from my side, and God bless you guys. Okay, take care and enjoy the break, guys. Thank you.